All right, let me do this. It's just over here. And if you guys have any questions, you can, I mean, since it's a pretty small crowd, you can just interrupt me. You don't have to type it. So this is my clinical approach to headache in the ED. And again, it's kind of a broad chief complaint. It's something that you'll see very commonly. But if you ask any resident or any attending what their least favorite chief complaint is, it's anything remotely involving neuro. And it's for good reason, because a simple headache could be a muscle strain in your neck to a life-threatening bleed. And so the differential is very broad. So in the overview, I just want to go over a few of the cannot miss diagnoses, what's in the high yield history, what you should be paying attention to, any red flags, or the most common red flag symptoms that should alert you, what you are likely to see on physical exam, differentials to consider, diagnostics, management and treatment. And I have an oral board case. I hope it's better than last time, but we'll see. So in the first 2 minutes, when you walk in the door or EMS comes and gives you a patient with headache, you cannot miss intracranial hemorrhage or any type of herniation, meningitis, subarachnoid hemorrhage, epidural hematomas, and subdural hematomas, and hemorrhagic strokes. There's a mnemonic that you can use if you want. It's called Bite Me. It's just blood infection, thrombosis, eye. So any eye complaints like visual disturbances or blurry vision. Mass and or eye pain, mass and any environmental exposure. Part of the high yield history, things you should probably ask and be listening to are, is it maximal intensity at onset? So there's a difference between I have a headache now, it's a 3 out of 10, and then 2 hours later, it's a 10 out of 10, versus when my headache came on 3 hours ago, it was a 10, it's still a 10, and nothing helps. Is it trauma or related, right? You're going to see this all the time in the ED for people who have falls and they're on blood thinners, or they just fall and they hit their head, they have a headache. Or in the younger population, it's going to like trauma or related. That's pretty benign, asymptomatic, are people who are in motor vehicle accidents and they get the whiplash and they're like post-concussive. You can see that there as well. So just keep in mind any recent traumas. If they're immunocompromised, a famous board question or step in the shelves are your HIV/AIDS patients that have a headache and blurry vision, and they have, I think it's like primary CNS lymphoma. You would just want to be on the lookout for any history that the patient tells you that may make them immunocompromised. Intensity, I mean, it kind of goes in with the first bullet. It like, is it a 10 out of 10 at its start and then now, or is it kind of like a gradual dull pain? Is this a similar to previous headaches? So one question that needs to be asked is, in addition to what you're talking about with the patient and headache, but you need to ask, have they had headaches in the past? And if so, does this feel very similar to previous headaches? Because if it does, it's less likely to be something extremely serious. But if they say no, it's different, then it's kind of a red flag. It needs to like make your mind go. Are they on any anticoagulation? So again, like mostly in your elderly population and anybody with that's kind of younger that has AFib are going to be on blood thinners. And even though the risk is very low, there is a risk of spontaneous hemorrhage or spontaneous bleeding. So that can happen. Any visual disturbances, this goes along with any type of intracranial hemorrhage that's involving the occipital lobe, or any mass or tumor that's pressing on the optic chiasm. And if they have any neck pain, so like a nuchal rigidity on exam, or if they have neck stiffness or pain with range of motion, especially passive range of motion, when you're doing the exam. Okay. The red flags of headache are, is this a first headache? And it's extremely important to note that in your people who are 50 or older with a new onset headache that they don't have a history of, they are associated with an increased adverse effects and pathology. Is it a different headache like we've discussed? Do they have facial tenderness? So things you want to think of, headache and facial tenderness are giant cell arteritis or temporal arteritis. Did they syncopize with the headache? Do they have neck stiffness? Are they complaining about it? Trauma, ill appearing, meningeal signs? Do they have focal neurologic deficits? And the big one here also is a red flag that not a lot of people think of, and you probably won't think of it on rotation, is if they're peri or postpartum. I'll just ask you guys, do you know about eclampsia during pregnancy? And my question is, how far after pregnancy or after a delivery of the baby can somebody be in eclampsia? Anybody know? Like how many weeks afterwards?
Isn't it like 6 to 8?
Yeah, so it's in general, it's about 6 weeks. So you just want to be very careful, especially in women of childbearing ages, if they have headache, and because not all the time will they bring a 6-week-old to the ER, right? You want to keep baby at home, to not get anything. So you just need to ask and be aware of the fact that women postpartum 6 to 8 weeks can still have eclampsia. And that is something that I was asked when I was on my EM rotation, and it does come up very rarely on the board exams. Physical exam. So vital signs are always important for every complaint, but especially in headache, they can kind of tip you in, do I need to go see this patient immediately, or can I just actually wait a little bit, kind of like get my bearings? Things you want to look out for in vital signs are bradycardia, high blood pressure, and fever. Those are the type of things that you want to go see that patient immediately. Make sure there's no intracranial herniation or any neurologic deficits or meningitis. There's a full ED and neuro exam, and it's supposed to be a fast exam. So basically, you go head to toe, and you do the cranial nerve assessment and H test first. Then you test the sensation of cranial nerve 5. So like the forehead, the cheeks, and like the lower jaw. You test bilateral upper extremity sensation and motor strength, so grip, push and pull, and then same thing with the lower extremities, plantar and dorsiflexion, and single leg strength, a heel to shin test, and a finger to nose test for the cerebellum. This should take right around a minute or less. It's a very quick exam, and you can get a lot of information out of it. If you are on internal medicine or surgery, I would just do this on every patient that you admit, because it's very good to just get in the habit of doing it. And then, of course, you just want to, like when you're up in assessing the head and the cranial nerves, just press on the temporal regions, just to see if there's any type of tenderness, because you don't want to miss temporal arteritis. So the 10 cannot miss diagnoses, it's actually kind of long. What I've done here is the stuff on the left is the stuff you'll commonly see in practice, more so than the stuff on the right. The right stuff, though, is going to be on the boards most commonly. So on the left, we have subdural epidural hematomas, subarachnoid hemorrhage, meningitis or encephalitis, hypertensive emergency, and carotid or vertebral artery dissection. I don't remember any board questions about carotid or vertebral artery dissections, but it's important to know any mechanism of high velocity trauma can cause this diagnosis. On the right, you have temporal arteritis, you have acute angle glaucoma, carbon monoxide poisoning, central venous thrombosis, and increased intracranial pressure. For the boards, temporal arteritis is usually, they're going to tell you it's usually a middle-aged female with polymyalgia rheumatica, and they'll have an ESR of like 100, and they'll have one-sided headache. Acute angle glaucoma, again, it's going to be someone who's elderly and they've just taken like 5 Benadryl, or any other anticholinergic medication can cause this. It is actually a medical emergency. Carbon monoxide poisoning, they'll tip you off by saying your patient has a headache, they were camping in their cabin in the mountains, it's cold, and then the family of 5 also has a headache, so it's environmental exposure. Central venous thrombosis is kind of like your headache that kind of has visual deficits. Usually it's in your younger females, but there really isn't much to do. And the diagnostic would be like an MRV. And then increased intracranial pressure. This is seen in your obese patients or young females sometimes, and you can more or less get this by the papilledema, or they'll tell you that they had a therapeutic LP. So the differential for benign headache are just, here's a few examples. It's not exhaustive, there's a lot more, but the most common that you'll see is tension headache, migraines, and cluster headaches, dehydration, post-lumbar puncture, and dental infections. Benign headache is the type of headache you'll see most commonly in the ED. So yeah. Diagnostics, so it kind of varies if you're talking about benign or deadly. So in benign headaches, some migraines, clusters, or tensions, there's nothing to do unless there's any red flags. And so the deadly headaches or the red flag symptoms that you get, you would draw a CBC, a CNP, coags. If they're female, childbearing age, a urine HCG, a CT head without contrast, plus or minus a CTA, again, plus minus an LP. It's just depending on the clinical picture. And then if you do an LP, you need to send off the CSF labs. And then I put subarachnoid hemorrhage out here because it's kind of like a nice little pimp question in the ED. Because it ties into LPs and why we don't do them as much. But if someone has if you're concerned for a subarachnoid hemorrhage and the onset of symptoms is within the first 6 hours, and you get a non-con CT and it's negative, you don't have to do anything else. Like you don't have to do an LP. But if it's outside the 6-hour window, then you also need to consider a CTA and an LP to kind of rule out subarachnoid hemorrhage. So the management and treatment of headache, I have benign headache on here because again, that's what you'll see most commonly, because the treatment for the deadly or the red flag headaches vary depending on what is causing it. So, but for your benign headaches, you typically can give 1 to 2 liters of fluids, just depending how the patient feels. Usually there's some portion of dehydration in there, especially in your patients who are either drinking alcohol or they're hungover. Toradol 50 milligrams IV after you've ruled out subarachnoid and they have no chronic kidney disease. You can use compazine or Reglan at 10 milligrams and Benadryl 25 milligrams IV. And you can use dexamethasone 10 mg IV. The reason why is because the number needed to treat is 9 for prevention of reoccurrence. And that's a really, really low number needed to treat. And something for board exams, you want to do prevention in low number needed to treat because it helps with better outcomes. As an example, aspirin's number needed to treat is 50. So it tells you that if you have someone with a benign headache, just give them 10 milligrams of IV Dex and they should be okay. Tension headaches, you can do an occipital nerve block. I've seen this actually increase in management and as an option, as more providers are getting more comfortable in doing it. Basically, if you put your fingers on the occipital protuberance in the back of your head and you go like 1 to 2 finger breaths, either to the left or to the right, and you inject diagonally, you follow that lesser occipital nerve in the back of the head. And if you numb it, it'll relieve a tension headache. And it works very well in the patients I've seen it been done on. And then, of course, if your patient is pregnant and they have a headache, unfortunately, you can only give them acetaminophen or Tylenol and any other like anti-dopaminergic agents. Yeah. So I do have the oral board case now, and the way it's set up is that I want to give you guys these scenario, and then I want you guys to like act as if I'm the patient. So you're gonna ask me all the questions and like what all the management stuff that you guys will like want to do, and then we'll work through it slide by slide. So you're working at Ross General when you get a call from EMS. They say that they're about 2 minutes out and they're bringing in a 65-year-old male with reports of a headache for the last 3 hours. They've obtained IV access and they're currently running 1 liter of normal saline. They gave 4 milligrams of morphine and Zofran for pain and nausea. Their initial vitals are blood pressure of 198/100, a heart rate of 70, and a respiratory rate of 12, a pulse ox of 94% on room air, AFib with a D-stick of 200. They arrived to the facility, and now, how do y'all want to start this patient encounter?
I want to ask what meds they're on.
So, okay, so the patient tells you that they're on lisinopril for high blood pressure, and they just take Pepcid for GERD.
Have they had any trauma recently? Have they fallen?
No, I've not fallen. I had no recent traumas lately. I'm pretty active.
Have you ever had this headache before?
From time to time. It's a bit different, but it feels about the same. It's just the only difference is that it's pretty persistent and my home meds don't help.
Was it a gradual onset or did it happen all of a sudden?
So yeah, it just kind of just came on out of nowhere. Usually, now that you mention it, usually my headaches in the past, they usually are gradual in onset and it takes a little bit, but this just came out of nowhere. It's really weird.
How bad would you say the pain was before you got the morphine?
I think it was like a 6 or 7 out of 10. But since I got the morphine, it's about a 3 or a 4 now.
Can you describe the characteristics of the headache? Is it aching, throbbing, sharp?
It's just kind of dull and like just constantly there.
On both sides or one side?
It's really just my left side. It's weird.
Any blurred vision?
I feel like my vision is blurry, but I feel like I can make out numbers if you were to hold them up. But my vision does seem kind of off.
Any nausea, vomiting?
I am a bit nauseous. I had one episode of vomiting prior to calling 911. Actually what prompted me to call 911 is that I felt weird at first. I took my blood pressure at home and I had a blood pressure of my machine read at 240. So I called 911 immediately.
Has your blood pressure ever been that high?
I mean, my doctor gets mad at me. He says I need to take my medication better and more consistently. I mean, but I've been trying though, but it's so hard and like I feel pretty vulnerable taking medication.
When was the last time you took your lisinopril?
Um, well, the last time I took it was 2 days ago, but when I saw it was 240, I took three.
Oh, three. Okay. Okay. Are you hurting anywhere else?
Nope. That's it.
Okay.
Are you feeling short of breath?
No, I don't think so. I think I feel fine otherwise. It's just this like this constant dull left-sided headache. It's weird. The nurse asks you, what interventions do you want to do? She's obtained a line. So I now have two IVs with one running and normal saline still. The nurse asks you, what interventions do you want to do? What labs do you want to draw? Any medications to give?
Oh,
I want a CBC with diff. I want a CMP. I want a trope. I want a BNP.
I want a CT with and without. And then we gotta treat your blood pressure.
I want an EKG as well.
Oh, that's good. That's good.
I don't necessarily want to treat the blood pressure considering he took 3 lisinopril. I want to wait and see what his blood pressure drops down to.
Okay.
Um, because we don't want to drop it too quickly.
Okay.
Plus, I want to see how his kidneys are functioning after all of this, the elevated blood pressure and the lisinopril.
Okay. Any other medications that you want to give or anything else you think his nausea is controlled? And what exams do you want to do? I guess physical exams.
Want to do a neuro exam.
Mm-hmm. Okay.
Want to check for any neck stiffness, tenderness, rule out meningitis.
So the exam comes back and basically your patient is in mild distress secondary to pain, but is otherwise fine. Head, it shows no obvious signs of external trauma. Neuro is the eyes are equal, round, and reactive to light, and they accommodate. The cranial nerves are intact. Has 5 out of 5 strength in the upper extremities. Normal sensation throughout. Heart and lungs are fine, and extremities show no edema. And then here's the labs. Only thing significant here is probably the creatinine at 2.2, troponin was negative, PTINR is 15 and 1.3. The glucose is 2, or the point of care glucose was 202. And on repeat, or on EKG, this is what the EKG shows. Anybody care to interpret this at all? Or is it a pretty benign EKG? We don't have to worry about it.
Let's see. It's not benign. What was the potassium?
4.9.
Oh, okay.
That's right. We can come back and talk about this.
Okay.
The only thing I was gonna say is that there's QT prolongation.
Okay. So that's good to know.
T-wave inversion lateral leads.
Okay, that's also good to know. Anything else? Anybody can identify at all? All right.
Like we can agree that's a high T wave, right?
All right, what?
We can see that's pretty high T wave, right?
Hmm,
No.
no, I mean, not really.
Okay.
We can come back to it. So the repeat vitals, he has a blood pressure of 202 over 102 and a heart rate of 62, afebrile still, but you do a repeat neuro exam and now it has 3 out of 5 strength in the left upper extremity and decreased sensation in the left upper extremity. So CT comes back and there's a massive intracranial hemorrhage on the left side. So anybody know what you would do from here? What you would classify this as? Not like this, but like the admitting diagnosis that I'm trying to get at, and what you would do from here.
Like an intracranial hemorrhage, and that you would send them for surgery.
Yeah, so you have this clinical situation, and then you have this intracranial hemorrhage. So obviously, like the top diagnosis is intracranial hemorrhage, and then it's due to hypertensive emergency.
Okay.
And from here, you would just consult neurosurgery, get the recommendations. It depends what they want to do, like medically manage, or if they need to come in and do a decompressive craniotomy or an evacuation. But anybody know where this patient would go? Because you've consulted neurosurgery and they said admit the patient.
I would think to the neuro ICU, right?
Yeah, neuro ICU or the surgical ICU, whichever your hospital has, and interventions that you can do without neurosurgery telling you is just elevate the head of the bed 30, 45 degrees. You know, just to decrease any unwanted or unnecessary intracranial pressure. But yeah, and then like they'll probably tell you that sometimes they'll tell you to do like mannitol or or like the hypertonic saline. It really depends what neurosurgery likes. Sometimes these patients need to be intubated as well. If they decline rapidly, then you would put the vent settings on the parameters to decrease intracranial pressure as well. But basically, at the end of the day, this patient was started on a nicardipine drip at 15 mg per hour and was admitted to ICU under neurosurgery. So the point I wanted to make here was just talk a little bit about hypertensive emergency, because it is one of those ones that people will come in for probably the most medically, because you see this all the time at like 8, 9, 10 p.m. Patients are like older patients are getting ready for bed and they just take their blood pressure, and then it's like, for whatever reason, it's 240 over whatever, and then they just come into the hospital. And so you're gonna see this, and you're gonna see it present in the way that it does. It may not be a real 240, but it could be. And so in general, with hypertensive emergency, the medications that you want to use or consider are nitroglycerin, 5 to 100 mics per minute, nicardipine, 5 to 15 mg per hour. Nicardipine is on a drip. And labetalol, 20 to 80 mgs, IV bolus, up to 300. But don't do it if there's bradycardia. in general, in the ED, most ED physicians and ABIM actually likes nicardipine for almost everything like regarding high blood pressure. But if you're not just quite there yet for a drip, because a drip usually implies you're going to the ICU or they're going to a step down, or that's where drips go. You can start with labetalol, see if they respond or not. Anybody know why like we're not using hydralazine? I don't have it on here for a reason. It's because we're getting away from it. Does anybody know why? That's okay. It's just because it's a pretty bad drug, and there's lots of adverse effects to it. It's only temporary change in the low blood pressure, and for no real benefit. So if you can't use labetalol because of bradycardia, just use nicardipine, or nitro. The goal in hypertensive emergency, and to know for your board exams and for yourself and for rotation, is you want to lower the MAP 20 to 25% within the first 1 to 2 hours. And then from 2 to 6 hours, you want the goal blood pressure to be less than 160 over 100. And it's for what you said earlier, Francisca, because you don't want to potentially make the patient stroke out or risk kidney damage or further, ruin the coronary perfusion pressure. So it's very important to not lower it too quickly. If you do have intracranial hemorrhage, as in this case, elevate the head of the bed 30, 45 degrees, give meds per neurosurgery, and you want to reverse any anticoagulation, give FFP or platelets if indicated, give tranexamic acid if indicated. And dispo, if it's true hypertensive emergency, admit to the ICU or step down unit, or if they have intracranial hemorrhage, the surgical ICU. And if they're truly asymptomatic, you can discharge these patients home and return if they have any red flag type of things show up. And that's it. This EKG though, we can talk about just a little bit. So whoever said there's T-wave inversions and there's QT prolongation, there's also a little bit of ST depression and there is bradycardia. So these kind of, like I said last time in the last presentation, these signs can kind of indicate there's increased intracranial pressure going on. Not all the time, but within the right clinical picture, it can. So just wanted to point that out there. And does anybody have any other questions or comments or concerns, or I don't know, anything?
I liked going through the board case.
Yeah, I tried it differently this time. It's hard to do it on a slideshow than how you actually would practice for it, because you're supposed to tell me what you want, and then if you don't initially say that you want a CT head, then I can make the patient crash or have a intracranial herniation or anything like that. But like you can't put like a CT all the way at the bottom or at the front. It's just kind of difficult to navigate that. But yeah, I'll work on it as time goes on too, like the way it's ran. So Thomas and Francisca, I know you just did your EM rotations fairly recently. Did you all see any hypertensive emergencies or any type of concerning headaches? Not trauma or not trauma related?
Had some migraines and had some hypertensive urgencies, but not really an emergency.
Same. I didn't have a hypertensive emergency, but I had a cluster headache, which was fun
Oh,
because you don't see those all the time.
definitely not. No.
Did have a guy with a head bleed. But he had history of previous head bleeds and had very low motor function and any kind of function already. So there wasn't much that they were doing.